Chapter 11 is the muscular system. We will be covering how skeletal muscles produce movement and some disorders that we'll see. So that's 11.1 and the disorder portion at the end of the chapter. So the muscular system specifically concerns skeletal muscles and the associated connective tissue that will make individual muscle organs. We'll discuss how skeletal muscles produce movement in our discussion of this chapter, but your chapter goes into further detail about describing the principal skeletal muscles. So how do skeletal muscles produce movement? They'll produce movement by exerting force on tendons, which in turn pulls on the bones or other structures such as the skin, and movement will occur. Most muscles will cross at least one joint and will then be attached to the articulating bones that form the joint. When a muscle contracts, it draws one articulating bone towards the other. The attachment to the stationary bone is the origin, and the attachment to the movable bone is the insertion. Tenosynovitis is an inflammation of the tendons, tendon sheath, and synovial membranes surrounding certain joints. Our skeletal movement is based on lever systems and leverage. So the bone will serve as the lever and the joint will serve as the fulcrum. A lever is going to then be acted on by two different forces. It'll be acted on by the resistance and effort. So resistance will be what we call or show here as our load. That's the resistance. And then we'll have the effort, where we actually have the work coming from. And we have three types of levers. These levers will be characterized according to the position of the fulcrum, the effort, and the load. So first is our first class lever. In our first class lever, the fulcrum is located between the effort and the load. So an example here would be a pair of scissors. And we also see that at our atlanto-occipital joint. So the effort will come from the muscles in our neck. The fulcrum will actually be in our spinal cord or our vertebral column. And the load would be our jaw or the front portion. A second class lever is going to have the load actually between the effort and the fulcrum. So an example that we know in everyday terms would be a wheelbarrow. So the fulcrum, that point from which we have the movement occurring, and then the load bearing in the center, and our effort is exerted from behind to push the wheelbarrow. So an example here would be when we rise onto our tippy toe, we elevate from the fulcrum or at the metatarsals, and then the load is within our foot and the effort comes from our calf muscles doing the work for us. The third class lever is where the effort is between now the fulcrum and the load. And so an example would be a pair of forceps, or you can think tweezers also. So whatever the point of attachment or where they're here is at the top, And then the tips where you're actually picking up the load, but you will squeeze or have your effort between those two. And so the example here is going to be at our elbow. If we pick something or lower something here from our hand, the effort comes from our muscle. And then remember, we've talked about the levers, the first, second class, and third class. And then this leverage is the mechanical advantage that we actually are able to gain by having a lever system. And so the leverage is largely responsible for our muscle strength and then also our range of motion. So range of motion is the maximum ability to move the bones of a joint through an arc. Oftentimes, we mentioned when we were talking about our bones, and if you have fracture and that disuse that occurs, then when you go to physical therapy, they'll look to try and get your range of motion back to normal. And so they use these arcs or protractors to measure what your range of motion is. So same thing here, this leverage is providing us with maximum range of motion. Now, the fascicles, remember those individual groups of muscle fibers that are arranged? Well, we have different arrangements or different effects from how they're arranged. So the arrangement of the fasciculi in relation to the tendon can vary. It can either be parallel within each bundle, it can be fusiform, or it can be pinnate, circular, or triangular. The muscle fibers are arranged in a parallel fashion within each bundle, but the actual individual fasciculi with respect to the tendon can take either of those patterns. The fascicular arrangement will be correlated with the power of the muscle and with the range of motion. So here we're showing the arrangement: parallel, fusiform, circular, triangular, and then in pinnate we have a unipinnate, bipinnate, multipinnate, but these will all allow for different amounts of power and different ranges of motion. When we coordinate within the muscle groups, we'll do this by several skeletal muscles acting in groups rather than individually. And so most of our skeletal muscles will actually be arranged in an opposing or an antagonistic pair at the joint. So if you think about your bicep and your tricep, you have an antagonistic pair there. So a muscle that causes a desired action is referred to as the prime mover or the agonist, and the antagonist will produce the opposite action. So with our bicep and our tricep, our bicep will allow us to flex our arm, while our tricep allows us to extend our arm. So if our goal is to flex, and that is our desired action, then the bicep is the agonist and the tricep is the antagonist. Most movements will also involve muscles that are called synergists, meaning they serve to steady a movement and thus prevent unwanted movements and help the prime mover or the agonist function more efficiently. Some synergist muscles in a group also act as fixators to stabilize the origin of the prime mover so that it can act more efficiently. Under different conditions and depending on the movement and which point is fixed, many muscles act at various times as prime movers, antagonists, synergists, or fixators. So it depends on the movement we are trying to create as to what the muscle is acting as at that given moment. And so we talked about stretching the last chapter, but we mentioned it again here because benefits of stretching: improved physical performance, decrease risk of injury, reduce muscle soreness, improve posture, increase synovial fluid, and increase neuromuscular coordination. But remember, stretching is a benefit when we have pre-warmed or already warmed our muscles. Now, as far as disorders and homeostatic imbalances go for our muscles or the muscular system, when we think about it functioning, we have running injuries. And so most of these running injuries will involve the knee. Other commonly injured sites will be the calcaneal tendon or the Achilles tendon, the medial aspect of the tibia, hip area, groin area, foot and ankle, and back, but most involve the knee. And so oftentimes these running injuries will be related to faulty training techniques. And so we say that initially we should treat them with RICE therapy, or if you add protection, PRICE therapy. So in RICE therapy, you will rest, you will reduce the inflammation, you'll apply compression, and you will elevate. And so you can also alternate moist heat and ice massage as a follow-up treatment after the RICE, after the initial injury. And then sometimes we have non-steroidal anti-inflammatory drugs being used, or local injections of corticosteroids that will help to reduce inflammation. And then an alternate fitness program could be necessary to stay active during the recovery period, followed by careful rehabilitative exercises. Compartment syndrome is where the skeletal muscles our skeletal muscles in our limbs are organized into units called compartments. So in compartment syndrome, some external or internal pressure constricts the structures within a compartment, resulting in damaged blood vessels and subsequent reduction of the blood supply to the structures within the compartment. Without intervention, nerves suffer damage and muscles develop scar tissue that results in permanent shortening of the muscle called contracture. Plantar fasciitis is a painful heel syndrome due to chronic irritation of the plantar at its origin on the heel bone. And this plantar aponeurosis at its origin on the calcaneus or the heel bone. So treatment here includes ice, heat, stretching, weight loss, prosthetics, steroid injections, and or surgery.